Protocol for managing amebiasis, giardiasis, and intestinal helminthiasis during pregnancy. This protocol provides a detailed, evidence-based, and safety-focused guide for obstetricians, covering diagnosis, drug mechanisms, treatment, and patient care. Step 1. Clinical assessment. History taking. Assess gastrointestinal symptoms. Amebiasis, bloody or mucoid diarrhea, abdominal pain, fever, in invasive cases. Giardiasis, watery diarrhea, bloating, flatulence, and fatigue. Helminthiasis, pruritus ani, abdominal cramps, visible worms, or signs of anemia. Risk factors. Travel to endemic areas. History of consuming untreated water or undercooked food. 2. Physical examination. Look for signs of dehydration, dry mucous membranes, tachycardia, nutritional deficiencies, pallor, anemia, edema, protein loss, systemic infection, hepatomegaly or tenderness in the right upper quadrant, suggestive of hepatic amebiasis.
Step 2. Investigation. Shared diagnostic approaches for amebiasis, giardiasis, and intestinal helminthiasis. 1. Stool analysis. For identifying parasites in the gastrointestinal tract. Microscopy. Conducted on 3 stool samples collected on different days to maximize sensitivity. Findings. Entamoeba histolytica. Trophozoites containing ingested red blood cells or cysts. Giardia lamblia. Pear-shaped trophozoites or oval cysts. Helminths. Eggs like Ascaris, hookworm larvae, or worm segments like tapeworms. Antigen detection. ELISA or immunochromatographic tests to identify parasitic antigens in stool. Benefits. Higher sensitivity and specificity than microscopy, especially for non-invasive cases. PCR polymerase chain reaction. Detects DNA of specific pathogens. Indications. Cases of co-infection where individual pathogens must be identified. Persistent symptoms despite negative conventional tests. 2. Complete blood count (CBC). Purpose. Evaluates systemic effects and complications of parasitic infections. Anemia. Normocytic anemia may indicate chronic inflammation or severe parasitic burden. Pathogen-specific tests. Amebiasis. 1. Serology. Identifies anti-Entamoeba histolytica antibodies, especially in invasive disease. Useful when stool tests are negative but invasive extraintestinal disease is suspected. Test options. Indirect hemagglutination (IHA) enzyme-linked immunosorbent assay (ELISA). 2. Liver imaging. Ultrasound. First-line imaging for detecting liver abscesses caused by invasive Entamoeba histolytica. Giardiasis. 1. Stool fat analysis. Elevated fat content greater than 7 gram per day in adults suggests malabsorption. 2. Duodenal aspirate. Purpose. Confirms diagnosis when stool microscopy is inconclusive. Method. Duodenal fluid is collected via endoscopy or a string test and examined for trophozoites. Helminthiasis. Serology. Identifies systemic helminth infections. Enzyme-linked immunosorbent assay (ELISA) detects specific antibodies for systemic helminth infections Toxocara or Strongyloides. Microcytic anemia. Suggests chronic blood loss due to hookworm infections. Eosinophil count. Elevated eosinophils greater than 500 cells per microliter strongly indicate tissue-invasive helminth infections. Common helminths. Ascaris, Strongyloides, Toxocara. Low serum albumin. Common in helminth infections causing chronic protein loss like hookworms. Associated complications. Edema, hypoalbuminemia-related fatigue. Imaging. X-ray. Indications. Intestinal obstruction, caused by large worm burdens. Like Ascaris bolus. Findings. Air fluid levels, visible worm outlines in severe cases. Ultrasound. Indications. Liver or biliary involvement like fascioliasis or intestinal complications. Findings. Hyperechoic or tubular structures in the affected organs. Amebiasis. Indications for treatment. Symptomatic amebiasis. Dysentery or extraintestinal disease, liver abscess. Asymptomatic cyst carriers. Delay treatment until postpartum if possible. First trimester. Paromomycin preferred treatment, Humectant and Gabaryl 250 mg. Dose: 25 to 35 mg per kilogram per day orally in 3 divided doses for 5 to 10 days. For a 60 kg adult, the dose would be 2 or 3 tablets 3 times daily. Safer during pregnancy due to minimal systemic absorption. However, it is still classified as FDA Category C. Mechanism: inhibits protein synthesis by binding to the 30S ribosomal subunit. Second and third trimesters. Metronidazole, 500 to 750 mg orally 3 times daily for 7 to 10 days. FDA Category B. Avoid in the first trimester, can cause nausea and a metallic taste. Mechanism: disrupts DNA synthesis in anaerobic bacteria and protozoa by producing reactive nitroradicals. Follow with paromomycin to eradicate luminal cysts, 25 to 35 mg per kilogram per day orally in 3 divided doses for 5 to 10 days. Giardiasis. Indications for treatment: symptomatic disease, persistent diarrhea, abdominal pain, or malabsorption. Delay treatment for asymptomatic carriers until postpartum. First trimester preferred treatment: paromomycin, 25 to 35 mg per kilogram per day orally in 3 divided doses for 5 to 10 days. Second and third trimesters. Metronidazole, 250 mg orally 3 times daily for 5 to 7 days. Avoid in the first trimester unless necessary. Alternatively, tinidazole-like protozole 500 mg, 2 grams orally as a single dose, less preferred due to FDA Category C. Generally avoided during pregnancy. Intestinal helminthiasis. Indication for treatment: symptomatic infections or significant worm burden. Delay treatment for mild, asymptomatic cases until after the first trimester or postpartum. Treatment options: first trimester, safe option: parental pomote like pin red 720 mg and combantrin 125 mg. Dose: 11 mg per kilogram, maximum 1 gram, orally as a single dose. If an adult weighs 70 kg, the dose will be 770 mg, 1 dose. FDA Category C. Considered safer than many other anthelmintic drugs due to its minimal systemic absorption but may cause mild gastrointestinal side effects. After first trimester preferred. Albendazole like albendazole 400 mg and alzantil 200 mg. Dose: 400 mg orally as a single dose, repeat in 2 weeks if needed. Mebendazole like antivir 100 mg, 100 mg orally twice daily for 3 days or 500 mg as a single dose. Albendazole and mebendazole both are FDA Category C, so both avoided during the first trimester due to teratogenic potential. Monitoring and follow-up. Treatment response. Symptom resolution typically occurs within 48 to 72 hours. Repeat stool examination 2 to 4 weeks post-treatment to confirm eradication. Supportive care. Hydration. Use oral rehydration salts (ORS) or IV fluids for dehydration. Nutritional support. Iron and folic acid supplementation for anemia. High-protein diet to address malnutrition. Pain management. Paracetamol is preferred for fever or abdominal pain.